Good afternoon, everybody. Thank you for joining this webinar series on autoimmune neuropathies. My name is Creu, and I would like to welcome you on behalf of the working group on peripheral neuropathies of the EURO-NMD. We have a series of very interesting talks, and today we have Dr. Luis Querol from the Hospital de la Santa Creu in Sant in Barcelona, Spain, to talk about the diagnosis and treatment of nodopathies. Dr. Querol graduated from the University of Oviedo in medicine and then completed his residency at the Santa Creu Sant Hospital in Barcelona. He trained as a Rio Ortega Grant awardee in neuroimmunology with Professor Isabel Illa and with Dr. Kevin O'Connor at Yale University, and completed his PhD in medicine also with Professor Illa, and his work was instrumental in identifying clinically useful antibodies in autoimmune neuropathies, and the first antibody against anti-conductin 1, which really initiated a whole field of disorders that Luis has contributed to its establishment, today known as nodopathies. And currently, Dr. Querol combines clinical care with laboratory and translational research. He is coordinating the group of autoimmune neuropathies and the autoimmune neurology group in Barcelona. He is participating in multiple steering committees for clinical trials, and in many consortia that study inflammatory neuropathies, including the IGOS, INC-BASE, and IMAGINE. And he also contributes to the writing of guidelines of the European Academy of Neurology and Peripheral Nerve Society for the diagnosis and treatment of CIDP and Guillain-Barré syndrome. Luis, thank you very much for joining. It's a pleasure and honor to have you and to talk about this topic that really has come out to a large part of your own contribution. So we're excited to hear. And after the talk, we will have some time for questions and answers. So I give the floor to you. Thank you.
So thank you, Cleopas. Very kind introduction. And thank you all for being here and listening to this webinar. Good afternoon to everyone. I need that someone tells me if you see my screen. If it's
perfect. Okay. Yeah, we see.
Okay. So yeah, we are going to talk about autoimmune nodopathies. The initial title of this talk was Diagnosis and Management of these Neuropathies, but we are going to provide a broader overview of the nodopathies because I think it's appropriate to put some context in where these neuropathies come from, etc. So first of all, let me check if this goes on. What doesn't go on now? 1 minute. This got stuck. 1 minute. Okay, now. Sorry. It's just going very slowly. Now, okay, sorry about that. So first of all, I have some disclosures, and some of them might have something to do with what I'm talking about, particularly the fact that we provide antibodies. My hospital provides antibodies, for, let's say, commercially, but otherwise, none of these conflicts has to do with what I'm talking about. I'm going to talk a little bit about the node of Ranvier in health and disease, and probably you know by now that the node of Ranvier is this structure that Ranvier described many years ago, 150, and he himself proposed that this should be an important structure for the nutrition and the function of the nerve, because it had these structural particularities that were not present in the rest of the nerve, and in fact, it's a very important structure, both functionally because it's organized to keep the sodium channels separated from the potassium channels, and this allowing for the saltatory conduction, but also is structurally important because it's the place where the union of the Schwann cell and the axon happens to start the myelination and to keep the myelination process. So it's important, and as such, the disruption of the node of Ranvier can be pathologic in many ways. As I said, the main function is to transmit the nerve impulse in a saltatory way. This happens in the central nervous system, but also in the peripheral nervous system. And we are going to talk about the peripheral nervous system, of course. It has to be acknowledged that, in fact, the concept of nodopathy, it's a concept that comes from the electrophysiological field. It was Antonino Uncini and Satoshi Kuwabara that described that there were some patients that had neuropathies, particularly autoimmune neuropathies, that didn't have either demyelinating or axonal neuropathies, but had something in the middle, in which there was a decrease of the action potential, the compound muscle action potential, that then was recovered in what they called the reversible conduction failure. And this was considered to be the hallmark, the electrophysiological hallmark of an alteration of the node of Ranvier. So initially, nodopathies were an electrophysiological concept. The node of Ranvier is not only disturbed in autoimmune neuropathies, but also in other neuropathies. In fact, now we know that there are some genetic mutations in proteins of the node of Ranvier that end up developing a severe neuropathy. Some of them demyelinating, some not, but very severe neuropathies in general. But also, in fact, the initial descriptions by Antonino Uncini and Satoshi Kuwabara describe that other neuropathies like ischemic or critical illness neuropathy could have these features of the reversible conduction failure, which were the electrophysiological features that were considered coming from the node of Ranvier disturbance. But of course, we are going to talk today about autoimmune neuropathies. I wanted to provide this context because it's not just that the node of Ranvier is altered in autoimmunity. It can be altered in genetics. It can be altered in toxic neuropathies, etc. But mostly the literature focused on the autoimmune neuropathies, autoimmune processes that attack the node of Ranvier and then give rise to a neuropathy. So one of them, of course, is Guillain-Barré syndrome. And this is because the GM1 ganglioside, and this is a picture here, the GM1 ganglioside, and this is known for decades now, it's enriched at the node of Ranvier, both at the node and the paranode. And in fact, one of the most beautiful pictures in autoimmune neuropathies about the node of Ranvier were published by the group of Jack Griffin many years ago, showing that both antibodies and complement deposited in the node of Ranvier, and these are Guillain-Barré syndrome patients, but also that even macrophages could infiltrate the node of Ranvier. They entered the nerve, let's say, through the node of Ranvier to cause this disturbance. More recently, the group of Hugh Willison described these very beautiful animal models in which they had knock out the GM1 ganglioside from the axon or from the Schwann cell, and the type of pathology that this caused, but the disturbance of the node of Ranvier and the paranodal areas in these models in which the antigen was GM1, as in Guillain-Barré syndrome, was really severe. So it's not just the nodopathies as we know them now, but also Guillain-Barré syndrome, in which the node of Ranvier is critical for the appearance of the disease and for the mechanisms of the disease. And not only even, let's say, neuropathies. You know that Casper2 is an antigen that causes autoimmune encephalitis, but also neuromyotonia. And this, in this case, is an antigen that is also present in the peripheral nervous system. In this case, is located in the juxtaparanode, and this gives rise to these muscle hyperexcitability or neuromyotonia syndromes that we don't usually study because don't fall into the category of autoimmune neuropathies, but in fact they are autoimmune neuropathies in a sense, and also nodopathies because the antigen is located in there. But of course they have other things like the encephalitis. But we are here to discuss more on the chronic neuropathies. And first, it has to be acknowledged again that in CDP, there were some studies before the description of the autoimmune nodopathies or the paranodal and nodal antibodies. In fact, there's this study from Cifuentes Diaz that is a pathological study on sural nerve biopsies from patients with CIDP, and they describe that the staining of the paranodes, the structure, the structural integrity of the paranodes was altered, and that Casper-1 and all the markers that usually are in the paranode were clearly destroyed or different from what they could see in the controls that were preserved. And in fact, also the group by Claudia Sommer and Katrin Doppler described that even in skin biopsies, in which you can assess myelinated fibers, there was this paranodal demyelination, this disruption that started at the paranode in patients with regular CIDP, that in this case, it was not the paranodopathies, it was just a normal CIDP patient. So it seems that the node of Ranvier it's important independently of whether or not you have these antibodies that we are going to talk about later. For anyone, or at least for a subset of patients with CIDP and Guillain-Barré, this is important regardless of them having these antibodies, which in other way means that the node of Ranvier is important for myelination and for the conduction velocities, and this is why it's an interesting thing to study. So yes, starting with antibodies. So when I was doing my PhD, so one of the things we did was this tissue-based assays in which you have rat nerve or pig nerves, and you just incubate the serum of the patient with these nerves, and then let's say develop this with a secondary antibody and see what is the IgG from the patient reacting against. And we had some patients that were having this beautiful staining of the node of Ranvier or the paranode of Ranvier, and we didn't know exactly which was the antigen. And about the same time that we were doing this, my PhD project, Jerome Devaux came with these beautiful pictures on patients with CIDP and GBS, also with Nobuhiro Yuki, showing that there were a number of patients with these disorders, with GBS, with CIDP, that had antibodies that went either against the node, the paranode, or both. And in fact, they already proposed some potential antigens, some of which we have seen later on in this paper that was published around the same time of the work we were doing as well. So let's get a step backwards, and what are autoimmune nodopathies? So first, this whole thing started with the study of CIDP, in fact. So CIDP is this neuropathy that you all know by this moment probably, in which we are looking for these electrophysiological findings, these demyelinating findings with the long latencies and slow conduction velocities, which we assume it's the electrophysiological correlate of the segmental demyelination, which is what you see here. This is these nerve fibers. The black thing is a myelinating Schwann cell, and the lighter gray thing is an axon, a nude axon. And you see here this segmental demyelination, which is the pathological hallmark of CIDP. And these were supposed to be equivalent. That's on the one hand. And second, we know that CIDP responds to immune therapies that target humoral systems. So, for example, immunoglobulins or plasma exchange that target the, let's say, humoral immune system. So with that in mind, we started looking for antibodies targeting the myelin sheath, and we found none because, of course, the logical approach is to look in the Schwann cell or look in the myelin when you are trying to identify the target antigen in a demyelinating neuropathy, but we didn't find any. And then Isabel, which was my mentor and that sadly passed away a few years ago, she was very intuitive, and she said, well, maybe the antigen is not in the Schwann cell, maybe the antigen is in the axon. And then we started culturing neurons, and in fact, this is an hippocampal neuron. This is not a peripheral neuron. And we saw that there were some patients that had this beautiful pattern of staining, and then we thought, well, we are onto something here, and then started looking for the antigen. And in fact, the curious thing was that these patients that stained the neurons were the same ones that were staining these paranodal sections in the tissue-based assays. Well, this all ended up in a description of the contactin 1 using immunoprecipitation, etc., in a small subset of patients with CIDP. In this, there were many people that were important, and the good thing is that these patients had, so for those of you that don't know what contactin is, it's in here. So it's one of the proteins that links the Schwann cell to the axon together with Casper. And this is the good thing of finding these antibodies in this very small subset of patients is that they had specific clinical features. So they had, at that moment, we thought that it was a disease that was predominantly in older people, but it's not the case anymore. And in fact, what it's holding true is that they respond poorly to IVIG and they have an aggressive onset in general. Not everyone, but in general, they have an aggressive onset. And then also they have axonal damage. In this paper, we described axonal damage as early denervation activity or spontaneous activity in the EMG, meaning that these patients, these axons were suffering, and the isotype of the antibodies was IgG4, and all this held true in the long run. One thing that we overlooked at the beginning, but was then later on published by many people, but even so, for example, the Oxford group, but also the French group, Emilien Dalmont, has a huge cohort of patients describing a nephrotic syndrome in these patients. We overlooked this finding, but it's now clear that contacting one patient between 30 or 50% of patients have this nephrotic syndrome. And then, as I said, it was confirmed in other reports, described in kids as well. It's not just of elderly people, but also in kids. But the phenotype has been refined a little bit, also with some patients that are very ataxic, severely ataxic. And this is, let's say, the main features of the disorder. We just published recently in Annals of Neurology a long-term follow-up of these patients with contactin 1. And one interesting thing is that they present very aggressively. They may not respond to some of the initial therapies, like immunoglobulins or corticosteroids, although some may show some response, like you see here, 20% of the patients may have some response to immunoglobulins. But one interesting thing is that they respond, of course, very well to rituximab. You may know this by this time, but importantly, only a minor subset of patients relapse after having an initial therapy with rituximab. And this is with a median follow-up of 35 months, but there are patients that have been 10 years or more treated now, and they are perfectly fine with a single cycle or a single course of rituximab. So bear in mind that having these antibodies doesn't mean that you're going to have the disease forever, because you may end up having a remission of the disease the same way it happens, for example, with masked myasthenia. Just bear that in mind. Importantly, these patients not only have the antibodies, but also have demyelination, but they have severe axonal damage by neurofilament light chain. And in fact, they have higher neurofilament levels than GBS on average. And the good thing is that this is recovered, you will see later. But another interesting finding is that these patients, so all of we have soluble contactin. So there's an isoform of contactin that is circulating in the bloodstream. So you can measure this contactin, and of course in these patients the levels are lower, even in most patients undetectable or in the very lower range of detection. And then when the disease is recovered, when the patient is well and the antibodies are negative, this this soluble contactin that is going around the circulation becomes normal again. And by the way, this soluble contactin is the one responsible, likely, of the nephrotic syndrome, because it forms immune complexes with the antibodies of the patient, and these deposits in the podocytes, in the basal membrane of the kidney. Well, this is the clinical evolution. So patients usually, if well treated, they go well, they respond really well to rituximab, and they become much better with whatever scale that we are using. But also very importantly, the antibodies tend to disappear, the neurofilament levels become normal, and the soluble contactin recovers. So we have 3 biomarkers to use to monitor disease activity in these patients, or to at least know if the patient is having a relapse, see if the antibodies are again positive after being negative, and this is of course a sign that maybe this patient needs to be retreated again. These antibodies are pathogenic. This was described by the group in Marseille at the very beginning in vitro studies, but most importantly, also there is pathological studies that show that these patients have some specific features, pathological features, and also there's a passive transfer animal model showing that IgG from patients causes a neuropathy by disruption of the node of Ranvier in the rats, and this is, let's say, more aggressively produced with IgG4 antibodies from patients than with IgG1, although IgG1s are also pathogenic themselves. Finally, not all patients are IgG4. There are some that are IgG3, and in fact, these ones may respond to immunoglobulins because, you know, the mechanism of action of IgG1 or 3 isotypes is different, is complement mediated usually, and this was illustrated by the group of Catherine Doppler and Claudia Sommer, and this probably accounts for this fact that some patients do respond something to immunoglobulins. Well, the second antigen, not the second to be described, but the second, let's say in homology with contactin is Casper1. So in this initial report, we had 1 patient that had antibodies against Casper1, but we only detected these antibodies when contactin and Casper1 were co-transfected in the cell-based assays. But then Catherine Doppler again and Claudia Sommer described the let's say the first patients to be pure Casper1 mediated patients. And these were patients that were associated with painful neuropathy. And this was the let's say the feature that was kind of surprising, because usually pain is not an issue in demyelinating neuropathies. So a few years ago, we collected a number of cases from many collaborators from all over the world, and Elba published this paper in which the initial features that were suggested by Catherine Doppler and Claudia Sommer were confirmed, but also some additional things that we could do with more patients. So, for example, one interesting thing is that apart from targeting the paranode of Ranvier, these antibodies target, at least in some patients, the neurons of the dorsal root ganglion, which maybe accounts for the fact that these patients have pain, that have a severe neuropathic pain. And in fact, half of the patients have neuropathic pain. It's important to know that when you test this by ELISA, it's a good test. We will discuss later about the tests. But if you use Casper and contactin together, which is the natural complex, it's much easier to see these antibodies. And as I said, these are patients that are presenting with a severe pain, but a demyelinating neuropathy, resembling a CIDP, but in some of them, half of them, they have a severe pain that is a little bit unexpected for this neuropathy. They tend to be very aggressive, even with respiratory involvement and cranial nerve involvement. And in fact, a number of them are diagnosed of GBS instead of CIDP. They, as it happens with contactin, they may respond a little bit to steroids or even to partially to immunoglobulins, but again, the main response is to rituximab in different series, and this is probably the best treatment for these patients. We don't know if these antibodies are pathogenic. There is a small report by Andrea Cortes and others showing that this may be indeed the case in vitro studies, but there are no formal animal models describing their pathogenicity. Well, the third antibody, and in fact, at least in Spain or Southern Europe, the most frequent one is Nodopathies 155. so this was initially suggested around the same time that Jérôme Deveau published his paper and we published the contacting one. This was described by the German group. They had these patients with either CIDP or AIDP that had antibodies against neurofascin 155 and that had this beautiful paranodal staining that we had also seen before. In fact, when we saw this paper, we started looking, of course, for these antibodies because we knew that contactin was an antigen. So neurofascin, which is the ligand of contactin, this should be something. And so the first patient that we saw was this patient that I'm going to stop a little bit because this was the first patient that we had with neurofascin 155. So you see how distinct this was. So he was a 46-year-old man that in the year 2000, he had this prominent ataxia and distal lower limb weakness and tremor. He had a diagnosis of CIDP because he fulfilled the criteria of CIDP and started different drugs, IVIG, plasma exchange, steroids, with not much success. And then 4 years later, he came to have a second opinion. He was from Granada, from another place in Spain. And we offered cyclophosphamide because this was let's say, the only thing we could offer. And he declined and then went to Granada again. And so in 2010, as he was doing poorly, he returned to Sant. And this is where this video was recorded in 2010. And you see this, he had, I'm not going to go through the whole video, but this patient has a severe distal neuropathy with distal weakness, prominent distal weakness, and this tremor. He had these proteins in the CSF and 2 cells. So, and also you can see here nerve conduction velocities of 15 meters per second, 22, 19. So unequivocally demyelinating. You see the F latencies of the ulnar and the median nerve of 100 milliseconds. So this is really a demyelinating neuropathy. So we described this patient with 3 others that we had. And in fact, all of them had a similar phenotype. But so you see how this went. So this is the patient that was treated for 14 years or something, or 13 years, and he had not responded to anything. We have this serum sample 10 years prior, then the immediately pre-treatment of rituximab, and the titers were exactly the same. So this patient had the same antibodies all the time during 10 years, and we treated with rituximab, and in fact, he didn't improve much, because he had a lot of axonal damage already, but the antibody titers became negative. So the patient improved a little bit and the titers became negative and never needed any other treatment, but he remained with significant disability. This is a different patient. So this one is similar in the sense that was not responding to anything. So you see how ataxic he is, and he has this tremor in the hand, the head, etc., which is very typical for these patients. And in fact, the antibodies of these patients stain the cerebellum, not only the cerebellum, but the neuropile in general, but also the cerebellum. And so we think and believe that this probably is not just a neuropathy, but also affecting other places, particularly the cerebellum. But we cannot demonstrate this yet. But the thing is, this patient was treated earlier. He was refractory to other treatments, but was treated in less than 1 year or 1 year or something with rituximab. And this is the patient a year later. So was doing really fine. So a real difference with the other one. Not only that, so this patient became negative for the titers, the antibody titers. You see here, the antibodies start here, then go down, and then become negative, and they remain negative for several months or years. And the neurofilaments become normal, but then he comes back in 2018. This is published in the paper that we described with the rituximab treatment. But then in 2022, he starts worsening back again. So, 6 years after the initial treatment, and then he's not very affected, but he started having this mild tremor again. That he had recovered completely. So this very slight tremor, and if you see the finger to nose you can see some slight ataxia that was not present before. So we repeated the antibodies became positive again. So this a very low titer, and we repeated the rituximab again and then recovered again. I saw this guy a month ago or so, and he's completely recovered again. So the antibodies help us not only diagnose, but also monitor these patients when they have worsenings. And then you can anticipate, let's say, a more severe worsening. Okay, this is there's another thing that I didn't mention, is that in these antibodies, not only adults are affected, or let's say elderly adults, but also it's relatively typical in adolescents or teenagers and young adults, and also in children after 10 years. So you can see that there's these two spikes of incidence, and be careful, because usually these kids are diagnosed with GBS instead of this, and the treatment, of course, is different. So have that in mind, because they don't respond well to IVIG as the others. Almost all these patients have, not all, but a very significant proportion of these patients have the same haplotype of HLA. And again, they have severe axonal damage. So that's why if you don't treat them promptly, if you don't identify them promptly, maybe after some years of not treating them, let's say, not aggressively, but at least with something that is targeted, this axonal damage that is happening, and you can see it here with neurofilaments, but you can see it also with atrophy and with the EMG. These will accumulate, and then the patients will not respond as well. If treated, the neurofilaments go down, the antibodies go down, and the clinical scales improve. So it's good to have them in mind. But we have to make a small comment on central and peripheral demyelination, because in fact, I have to acknowledge that neurofascin antibodies were described before in multiple sclerosis, although there was no confirmation afterwards. And in 2013, very closely to the description of these antibodies against neurofascin 155, this Japanese group published that patients with these antibodies had also central demyelination that could be optic neuritis, but also let's say a CIDP-like disorder, or any other sign of central demyelination and a CIDP-like disorder. This was not confirmed by in European cohorts, and in fact ourselves didn't have any patient with neurofascin 155 that had demyelinating lesions either in the optic nerve or in the brain. But we started testing some patients with from, let's say, Asiatic ancestry, and in fact we started seeing that some of them do have optic nerve demyelination or central nervous system demyelination of any kind, that is in fact in some of them reversible. So particularly when you have an Asiatic patient with these antibodies, or at least with combined central and peripheral demyelination, think about these antibodies, because even the central nervous system part could be reversible. I don't know why this happens in the Asiatic ancestry and not in the European ancestry, but that's how it goes, at least not much in the European ancestry. These antibodies are also pathogenic. This is how, this is a beautiful image from the French group, in which they show that patients that have these antibodies detach, or have the axon and the Schwann cell detached slightly. So they have this gap between them two when it should be like this. And this is the same image that you can see in a conditional knockout of neurofascin in an animal model, let's say. So it looks like the demyelination in these patients is not, let's say, macroscopic, but it's just this microscopic detachment of the Schwann cells and the axons. And also there is the formal demonstration that these antibodies are pathogenic in animal models by passive transfer. When you transfer these antibodies intrathecally to these animals, the neurofascin is not incorporated to the paranode and ends up producing a neuropathy that is very similar to the one that we see in our patients. This is the animals injected with the antibodies coming from patients, and these are the normal controls, let's say. And you see that the animals are ataxic and they have this, let's say, motor neuropathy similar to what patients have. And almost the last one is Pan-neurofascin. So in this case, there's a lot of confusion with this, because one thing is to have only antibodies against neurofascin 155. This protein has a domain that is exclusive for this protein, but there are some other antibodies that target a domain that is common to all three neurofascins. And this is what we call pan-neurofascin, usually identified by antibodies against the neurofascin 186. But not only, these patients also have 140 and 155. But it's different to have only neurofascin 155. The phenotype is different. The clinical associations are different. And having all three, it's a separate disease. These are the patients. So nodal neurofascins are located at the node of Ranvier. These are the patients that I showed before that have this staining that is located at the node itself, not so much to the paranode. You see there's some degree of paranodal binding, but most of the binding happens at the node of Ranvier. And this was described, by the way, by Emilien Delmont and Jérôme Deveau with a very severe case of autoimmune neuropathy that was behaving not as one would expect as a GBS. And this ended up having anti-neurofascin antibodies, but not neurofascin 155, but neurofascin 186 and 140, which are the nodal isoforms. They are severe again. They can also present with GBS-like syndrome with respiratory failure, being in the ICU. They also can have nephrotic syndrome to a lower extent than the contactin one, but pretty frequent anyway. This guy that I was mentioning from the Canary Islands also had a nephrotic syndrome, and then they don't respond well to immunoglobulins. In fact, so the German group, Catherine Doppler, and also the Oxford group describe this as a fulminant neuropathy, sometimes, particularly when they are associated with isotypes of antibodies that are different from IgG4, IgG1 or IgG3. So this, as you know, the Oxford group describes it, it's a severe yet treatable neuropathy with a high mortality. So we have to be aware that when a GBS patient is not going well, we have to think about these disorders as well. Are these antibodies pathogenic? We don't know, but we assume they are. There are some features in the ultrastructural pathology that look different from normal controls, like the microvilli of the Schwann cells at the node of Ranvier, but also there are some in vitro studies, and this is very beautiful by Louise Appelshauser and Catherine Doppler, showing that both neurofascin 155, but also, for what it's important here, pan-neurofascin disrupt the paranodes of Ranvier, and in fact, this is in the pan-neurofascin is in a complement-mediated fashion, leading to severe paranodal destruction, but also to axonal damage as measured with neurofilament light, clearly different from what it happens to neurofascin 155. That also is also high, but lower than pan-neurofascin, and that recovers when you treat the patients properly. And finally, this is the last one, is LGA4. And in this case, this is a novel autoantibody that has been described very recently. It has to be said that it needs to be replicated. So far that I know, there's no replication study. In this case, it's an antigen that is located at the juxtaparanode. You may know the LGA1 antibodies of the central nervous system. So this is a similar protein, but located at the juxtaparanode of the peripheral nervous system. These patients have not only binding to the juxtaparanode, but also to the dorsal root ganglia, to the satellite glial cells. And in this case, they are described as relatively typical CIDP patients, again with a subacute onset and very high protein content in CSF, which is a common feature for all the nodopathies with IgG4 isotype and partially responsive to IVIG and steroids. Well, so these patients respond to different things. So I've been very, let's say, a strong advocate of the use of rituximab early on, but in fact, to be honest, there is a subset of patients that respond really well to steroids. So you can start with steroids, and if it doesn't work, then move to rituximab. There's a recent report by Yang Jimin that even they can respond well to mycophenolate. We haven't tried this, but I'm putting this because it's recent material, but also they can respond to plasma exchange, but it's of course transient, and to cyclophosphamide. There are several reports out there, but mostly what you will see is that they respond to rituximab. And in fact, as I mentioned in the different cases that we've seen, the clinical scales upon treatment with rituximab improve, the antibodies decrease, the neurofilaments decrease, etc. So these antibodies were initially described within the spectrum of of GBS and CIDP, but since the publication of the last diagnostic guidelines of CIDP, these disorders are down here, which means that they are not CIDP anymore. They behave chronically, they fulfill CIDP diagnostic criteria, but they have these features that are let's say, clearly different from regular CIDP, and then it was consensuated to remove them from the CIDP spectrum to not mess in the case of clinical research and clinical trials, etc. So now we have this novel category that is autoimmune nodopathies, and that's why we now mention them as autoimmune nodopathies. And the last slide is to give some, let's say, advice on autoantibody testing. So there are some different ways of testing these antibodies. And recently, this is just now, we published this report. This was a collaborative effort by 4 different laboratories in Europe, trying to validate the best way of testing nodal and paranodal antibodies. There are some reports doing Western blot or dot blots, etc. But and these have not been assessed here. But in fact, what I wanted to say is that first, if you choose an appropriate test, and these are mainly ELISA cell-based assay with live cells and cell-based assays with fixed cells, the performance is really good in general. So they have very high specificity and sensitivity. But there are some that do better than others. And if we zoom in to this graph, you see here that the live CBA, so a cell-based assay performed with live cells, not fixing them, which is trickier because you need to grow cells all the time and you cannot have them fixed in a slide. It's the best one, but also, you know, if you use an appropriate ELISA or an appropriate fixed cell-based assay, it can do pretty good job anyway. So, but these are the tests that have been validated. So other tests like dot plots, Western blots, etc., may have some other problematics, particularly with false positivities. And I encourage you to use some of the validated tests. In this paper, you will find, if you have a laboratory, you will find the exact protocol for the best live cell-based assay, the best fixed cell-based assay, and the best ELISA assay. So you could maybe incorporate those to your own labs if you wish to do so. If not, we would always be happy to test these antibodies. And so in summary, the node of Ranvier is a vulnerable site for different types of neuropathies, not just for autoimmune ones, but particularly in autoimmune ones. The nodoparanodopathies are defined by the electrophysiological findings, but also now with the autoantibodies in a specific subset of inflammatory neuropathies. Several specific clinical features may guide us in the antibody testing, although we test any patient with CIDP and any patient with GBS, but I understand this may not be available for anyone. The treatment with rituximab is very effective, but it's not the only thing that is effective, and it's very important to treat promptly and to treat as aggressively as necessary, and not necessarily forever. And it's important to do it before axonal damage has not appeared yet. And finally, I think this group of disorders proves that when we reach an antigenic diagnosis, when we get the antigen right, we can understand a lot of things that were not so clear before knowing the mechanisms of disease. And with that, thank you very much. This is the group that enables all this, and I will be happy to take any questions. Thank you very much.
Thank you very much, Luis. This was an excellent overview of all the pathophysiology and immunology and clinical features of this group of rare autoimmune neuropathies that we call nodopathies. I see some questions, first of all, by Jintaude Samusaiti. The question is, in Neurofascin 155 neuropathy, is clinical improvement accompanied by improvement in nerve conduction study findings?
Yeah, that's a good question. So I don't talk much about electrophysiology because it's not my area of research, etc. But there are some papers out there that you could look. There's one from the French group or Yusuf Rakabali and others. So yes, they do improve, but I have to say that they improve much less than clinically. So they improve a lot clinically, and not, they improve also a lot electrophysiologically, but still there are some residual findings. So it's not like that they go in parallel. So usually in this case, the clinical is good enough, let's say.
Can I add to this? So at the pathophysiology level, do you think after treatment, the same node of Ranvier will be re-established and put back into normal function, or there is demyelination and then a formation of new nodes and perhaps shorter internodes? Do we have anything about this?
So the short question is we don't know, but the hypothesis to me is that I wouldn't expect them to have shorter. So I don't think it's demyelination. In fact, the ultrastructural studies that don't have demyelination, overt demyelination. So I think it's just a recovery of the previously functional node of Ranvier. And in fact, to me, so when these patients go well, they go really well. And to me, the main driver of this thing is the amount of axonal damage. So, for example, the main difference between these two guys that I showed, so the guy from Granada and the other guy that was severely ataxic, was the levels of neurofilaments. So one of the main differences, and the other guy, the ataxic one, he had not higher levels than normal neurofilaments, but not really high, despite being really severely affected. And I think this relative protection of the axon is what made him become normal completely, while the other one had atrophy, had it was unrecoverable. So I think the driver of the prognosis is more the axonal damage than the shorter internodes, etc. But in fact, we don't know. We would need to have serial pathology, which we don't.
Yeah, thank you. So the other question, which I think is also very important, is for treatment of autoimmune nodopathies with rituximab, do you give a scheduled course of rituximab, or do you wait for a relapse before retreatment?
Yeah, as I said, so we don't do that. So we don't treat continuously. We do the initial course, which in our case is 4 doses, weekly doses, 4 weekly doses, 375 milligrams per meter square. And then after these 4 weekly, we repeat at 1 month and at 2 months. And then we don't do anything. We just wait. We see the antibodies go down. We see the patient improve. The neurofilaments go down. We also keep track of these. And if this goes as it should be, usually the patients, most of them don't need any other treatment, even years after. I put this patient that had this slight worsening because it's very paradigmatic. So it was years after the course of rituximab, then he starts having minor symptoms. So it's not that they cannot relapse, they can relapse, but it's a fraction that depends on the antibody. So for example, in contactin it was around 10%. In Neurofascin 155 is more around the 30% or something like that. But it's absolutely not necessary to treat them forever every 6 months, which will save a lot of immune suppression, of course.
Is there a way to predict the risk of relapse? Is it the same risk in all nodopathies, or
no? It's higher in neurofascin 155. Usually, Casper, contactin, and Pan-neurofascin these three are more severe when they present, but in the end they recover better and they don't relapse so much, in my experience. While on the other hand, the neurofascin 155 is less severe at the beginning, but it's more relapsing and has more residual damage. And the only way to predict this, or at least the one we use, is monitor the antibodies, every 6 months or something. And when you see that the antibodies reappear, then you start thinking that maybe there's something going on.
Okay, good, great. The other question by Nick Wilcox is, any ideas why are the antibodies IgG4? Why do these particular targets autoimmunize?
Yeah, so that's a good question as well. No, I don't have specific ideas. So for some reason, these glycosylated antigens promote this type of response. And this strong association with HLA, by the way, is something that you see in all IgG4 mediated disorders. This happens with MASH, it happens with AGI1, it happens with many others. So I guess there has to be some allergen or some antigen in the nature that, when presented through this HLA, elicits a response that is autoreactive in the end, or is cross-reactive in the end. But we have done, so this is unpublished, but with this hypothesis in mind, in fact, being IgG4 and an antibody that is made to tolerize allergens, we checked for allergens with allergen arrays, etc., and we haven't found anything. We haven't published this ever, but I can tell you that this was not fruitful research. But yeah, it's intriguing. We don't know why, but it's something that happens in other, let's say, neurological antigens as well. So it may have something to do with the nature of the antigen, with the phylogeny of the antigen, or with the immune responses of the nervous system.
Great, thank you. Another question, which I think you already covered, is what are the clinical difference between conductin-1 and Caspar-1? I think that
so mainly the two main differences are, so Caspar-1 tends to have pain, really unexpected pain, let's say, because pain, we all can have pain, but this is a really unexpected pain for a demyelinating neuropathy. And the other one is the nephrotic syndrome. So Casper doesn't have nephrotic syndrome, while contactin does. Pain is not usually present in contactin, while it's present in Casper.
Great, thank you. Another question by Manel Tipuk is, what do you have patients that have almost pure motor clinic that resembles ALS?
No, I have to say that all of them are very sensory motor. It's not like in GBS that you have these, AMAN phenotypes or pure motor phenotypes. In here, it's very sensory motor. In general, all of them have sensory motor, and in fact, as I said, with neurofascin 155, but also with contactin, they have severe ataxia, for example, and this is something that is not so common in GBS, for example.
Okay, thank you, Luis. I see another question, but I think that was already. It's about what is the treatment used in first intention in neuropathy with neurofascin 155?
So yeah, so what we do, so of course we have the antibodies. We do antibodies every week, and this means that we have them very easily available, and we usually start, if you have a neuropathy that is, let's say, a GBS-like neuropathy or a GBS, we start with plasma exchange many times. If we have this severely acute neuropathy, we have plasma exchange. We, by default, use plasma exchange in many GBS patients. I would say almost all patients, but not. It's not true. It's almost all. And then you go on, because plasma exchange works either for GBS or for CIDP or for whatever. and then have the antibodies. If the antibodies are positive, then you just give steroids and rituximab usually, or steroids followed by rituximab, but we very promptly use rituximab. And if not, then you keep going on with plasma change until this is resolved, or the patient starts to improve, and that's it. That's for the very acute ones. And for the more chronic ones, we tend to do a cycle of immunoglobulins, but as we have these very early on immunoglobulins or steroids, it doesn't matter. But if we have this very early on in the first week, then we can switch immediately to something else when the patient is positive for these antibodies.
So you routinely check for these antibodies in all patients with GBS presentation?
Yeah, in fact, we check in any neuropathy in which we believe the features could fit. And this, by the way, for example, I didn't present it here because I had too many slides, but we have one patient that is a very interesting one that developed a neuropathy after hematopoietic stem cell transplantation for an acute myeloid leukemia. And the patient developed a neuropathy. Everybody was thinking that it was a neuroleukemosis because it's what one would expect, but a painful demyelinating neuropathy, and it had Caspr-1 antibodies and recovered only with rituximab, and it's now perfectly fine. And so this didn't fulfill criteria for CIDP or GBS because it was, in the context of the transplantation, but did have the antibodies and recovered with a drug that shouldn't work in a leukemia, let's say, a myeloid leukemia at least.
Great. So there is another question about what do you recommend for countries who do not have access to antibody testing for screening and treatment?
That's a good question. So, well, first of all, it depends on where is the country, but we are testing these antibodies to many people for free. I have to say this. We mean my lab. I don't know if other labs, probably they do as well. So because we understand that this is difficult. I have to say that now, and if you are motivated, you have a step-by-step protocol to develop, for example, an ELISA that is pretty good, the ELISA. And in this paper that I mentioned on the interlaboratory validation, there's the protocol exactly step by step. So any ELISA is relatively easy for any, let's say, routine lab. So if there's no one in your country doing this, maybe there could be someone that sets up this ELISA and have some agreement with some of us to validate the positive by ELISA with a cell-based assay, and then you would be covered with that. So I think now that we've seen that the ELISA is pretty good for screening purposes, I think it's going to be easier for any lab in any country, even in those that are less resourced.
Great. Thank you very much, Luis, for the presentation and for answering all the questions. This was really very interesting and enlightening. Thank you all for joining the webinar today. And reminder that we have a continuation on the webinar series. Next week, we will have a webinar on multifocal motor neuropathy, diagnosis and treatment by Thomas Harper and Emilien Delmont. So please join us next week as well. Thank you very much. Thank you again.
Thank you very much to everyone.
Thank you, Creu. Thank you, Luis.
Thank you.
Thank you very much. Bye-bye.
Bye.